everyone. Welcome to Your Health in Your Hands. I'm Dr. David Ajibade, and today we're going to continue our talk with Dr. Benjamin Obire, who, if you remember, we had him on to talk about how to address emergency situations on the streets. And now he has an amazing company, and I got to tell you, it's an idea that in my mind is I don't understand why we haven't had why someone hasn't come up with this idea. But again, that's the whole nature of ideas. They come up and it's like that's obvious. Everybody thinks that's obvious, right? But no one has actually gone ahead to implement it. And just as a quick recap, he has a company that is out there as the first responder, so to speak, at homes and offices on the streets, whether it's a road traffic accident, whether it's whether there's another kind of medical emergency, and they get there and they help to stabilize and give first, whether it's first aid treatment or the first aspects of treatment, while arrangements are made for the doctors or the ambulance or any other medical professional to come and take care of the rest. I think that's crucial. And he uses motorcycles, not just cars now, because as you know, the streets of Lagos, it's really hard to navigate those streets, especially in busy hours or busy days. So he has got a lock on that and is working with the governments in Lagos, and I believe spreading it to other cities around the country. And we wish him all the very best at that. So without further ado, I want to welcome Dr. back to the show. Welcome, sir.
Thank you very much. Nice to be here.
Absolutely. Again, big congratulations for what you're doing. This is very, very important, and I know we're going to talk about it some more topics now. But I really, since the last time we talked, have there been any updates, anything that you think our viewers should be aware of?
Yes, so one of the something that we actually just added to, because I listen to opinions of people who respond to my post, and also people I talk to just to find out what the pain points are in Nigeria. A family friend of ours has son died in Nigeria. They flew in from the US. He died because he had what's it called, an attack, his sickle cell. So he had an attack and he died in the waiting room. So one thing I found out also, because when my wife and I were trying to bring our kids here, we're like, hey, how do we have Blue Cross Blue Shield in the US? How do we make sure we get the same level of care here? And we found out if you're an American citizen, there's a number you can call. It actually goes, the same clinics the US Embassy uses here in Lagos, you can actually leverage the same clinic. So that came up, I now came up with an idea called Travel Safe. So meaning if you have anyone from diaspora coming back to Nigeria for a holiday, they could be rest assured that they don't have to worry about if I catch malaria here, if I do this here. We treat them, preventative medicine, one. Then number two, we extend the same solutions we're deploying here to them as well. Meaning if regardless of where you are, but in most cases on the island, if you have malaria, you just came to Nigeria, you came from the US, the UK, anywhere in the world, and you're like, I don't know this hospital, you have no idea how to get to the hospital, or you don't trust the hospitals. We actually bring the ER to your house. We triage, we bring ER to your house, treat you as if you're out there in the US. We actually also have your medical records uploaded onto our EMR system. So we know exactly what illnesses you have, what allergies you have, and we can treat you ahead of time. So we stabilize you, we treat you at home, give you the same level of treatment you get in the US or outside the country here. And also you have the option to get the second opinion service as well, meaning we can call your doctor and your doctor can actually patch into the call and give us, another opinion based on the treatment plan we deployed for you, or get another doctor within your network. And the insurance companies actually will pay for the fee, pay for the service, because you're leveraging the insurance you have in the US down here. So you get a reimbursement of treatment. So it's like a, peace of mind, safety net when you're here. and you don't know, I mean, you fall ill, you have any medical issues, we're there to take care of you.
Okay, that's cool.
Yeah.
I was also trying to find out how do people, what do we call them, expats or returnees? How do they
Yeah.
know about your service? Because like you said, some of these people do not trust the Nigerian system, and
Yeah.
they may not know what the terrain. So how do they find out about you?
We actually have it on LinkedIn, on social media. So we're pushing hard to make that more visible on social media, on Facebook, Instagram, LinkedIn, and also TikTok.
Got it. Got it.
Yeah.
Okay. Okay. And I'm sure there should be some kind of organizations too in that you can reach returnees in general, or returnees can get to know about you, or
Like
returnees.
travel agencies, we're going to reach out to travel agencies, airlines as well, and
Okay.
also embassies, because
Yeah.
like myself and my wife did, we called the American embassy saying that we're going to Nigeria with our kids and everything. So the embassies, those places are places where we're working hard to reach out to and make sure we create the awareness from there as well.
Excellent. All right, we're going to take a short break now. Don't go away, folks, because we're going to talk about uh, conditions, emergency room conditions that you definitely can relate to, and how best to treat them in this changing world. See you soon. Welcome back. Now, Dr. Obire, let's talk about some common emergency conditions that you have observed from your lens of having worked and trained in the US. Um, by the way, did you ever work in Nigeria before returning in,
No,
never?
never worked in Nigeria. No.
So some things are clearly have shocked you since you've come back, right?
Absolutely, absolutely, absolutely.
All right. No, I know we understand it. We understand that things are not going to be the way, like Johns Hopkins or is it Chicago, Cook Hospital, Cook Medical Hospital
Cook
in
County.
Chicago, Cook County.
Yeah,
Yeah, it's not going to be the same thing.
yeah.
But so what we want to do is we want to talk about practical things that you see that can be, and we'll choose specific kinds of conditions that you think can be improved on within the constraints of our system in Nigeria.
Malaria is one of the most prevalent illnesses that have noticed in Nigeria, in Lagos. It affects children and adults, and it's always very, very, you have, especially during rainy season, you have a lot of cases. And I think one thing I've noticed is the treatment plan for malaria in Nigeria is kind of missing, the point. You find out the first thing they do, for patients when they get to the hospital is, how much do you have to pay? We don't have enough beds. We don't have medication. You have to buy your medication. Those things should never be the first line of action. Treat the
Okay.
patient, then now talk about the treatment last. Then we now have so the way to treat malaria is, first of all, triage them, assess, understand, make sure the patient is conscious, breathing, get the vitals. Then the next thing is deploy a rapid test to ascertain exactly what kind of malaria parasites they have. So once you do that, the next thing, you now start stabilizing them. And in some cases, they get, into hypoglycemia, whereby it's, the blood glucose level dips, and then you find the patient being, confused, and, in that aspect, in that time, you have to make sure you now start deploying, IV fluids. You
Okay.
monitor complications, of the malaria after you've done your rapid test. You make sure you watch out for anemia, renal failure, seizures, depending on the level, because in some cases, people don't treat on time. They try to administer home treatment before they get to the hospital. And then, after that, you now make sure you monitor them. And those are the things that I believe is missing in the treatment plan or the protocol in some Lagos hospitals. So there has
Yeah,
to be universal protocol deployed for malaria treatment.
makes perfect sense. The challenge is that is a constraint. When the doctors and nurses are asking how much you have, obviously I'm not trying to defend it, but they have they, maybe they've been instructed by the management that we can't treat on unless they have some kind of money to pay for it. Otherwise, it's going to come out of your pocket. Speaking to the nurses and the doctors, if you treat
Yeah.
them without covering this thing, it's going to come out of your pocket. So that's seems to be like a dilemma for many people who may want to do the right thing but are unable to.
Yeah, I think that's true. So I think that there are ways to mitigate that. There has to be an enforcement by the government.
All
Treat
right.
first, ask later. So that's number one. Then number two, there has to be the insurance companies have to actually do some upfront payment. Like create a bucket whereby there's an upfront payment for if you show up at the ER, that covers part of your treatment. So automatically no one asks you anything. So they treat you. Malaria is a very basic illness. It's not something like, a broken limb where you have to call specialists, different specialists to come and, operate on the patient. Malaria is very, very basic. So those like the IV fluids, the rapid test to determine what kind of, malaria parasite they have, those things are not expensive. So those should be upfronted by the insurance companies in the bucket, whereby, like I said, you head to the hospital, they verify your insurance eligibility. You have a bucket that actually takes care of those. Once you treat the patient, when it now comes to maybe admitting the patient or triaging them to maybe ICU or whatever, that's when you can now start talking about billing and payment. But first of all, get them treated. People die every day of malaria in hospitals. They turn them back. It's a shame. It's a shame.
Yeah, it really is. I mean, it's shocking to me that people still have and you mentioned adults. I thought it was only in children that we would have all this cerebral malaria where they have seizures from malaria. Are you telling me that even adults have seizures from malaria?
Absolutely. Remember, the body system reacts to different illnesses in a different way.
Yeah.
First of all, the overarching issue in Nigeria is stress. That's number one. You find out someone who leaves his house at 4 a.m. in the morning to get to work at 7, then leaves work at 6 p.m. to get home at 11 p.m. Diet, the stress, not enough fluids. So, I mean, all those things are contributing factors to when you now get hit with malaria, it takes a downward turn very, very fast compared
Wow.
to someone that eats well, that has all the necessary vitamins, vitamin D, vitamin C, vitamin K, everything, and in them at the right level, compared to someone that doesn't even eat fruits, maybe just once a week, or no vitamin C, no vitamin D. So those are kind of the factors that actually, make it affect, adults in most cases.
Got it. All right. We're going to take a short break now. We'll come back into another aspect or another condition that Dr. Obire has issues with about how it's being treated in hospitals, and we will listen to his suggestions or his recommendations. See you soon.
Okay.
All right, welcome back. We are here with Dr. Benjamin Obire. Fascinating discussion about what an ER doctor from the U.S. Feels needs to be done to improve uh, ER treatment, emergency room treatment in Nigeria, beginning with Lagos. So, welcome back, Doc. Talk to
Thank you.
us about road traffic accidents and what you've observed and what can be done.
Yeah, so that's called the RTA, that's a road traffic accident, sometimes without trauma and with trauma. So I remember my first month in Nigeria, that last year, and I witnessed someone being hit by a car on his bike,
Oh, you saw it
and
happen.
I saw it happen. Yes, I mean
Uh-huh.
I didn't see it happen immediately, right in front of me, but we were in traffic, and we were probably about 7, 8 cars before the incident. So we just got there. We were there when it it happened. So we drove down and I asked the driver to park. He parked and I was like, can I just go down and help you? He was like, no, if you do that, then that means you're in trouble. They'll pin the liability to you that you hit the. I said, well, but the car doesn't have any scratches or whatever. And if the guy is alive, he should be able to tell them that I didn't, I stopped for him to help him. He said, no, you don't think that way. This is a different ballgame. So painfully, we sat there and so I saw the guy take his last breath. That was something that was traumatic. He was bleeding from the head, and I'm sure internal bleeding as well. Nobody could do anything. I had my stethoscopes in the car. I had some of my tools in the car, but I couldn't do anything. It was so painful. So that's also something you see people. Thank God, I remember 30 years ago or 30 some years ago before I left Nigeria, we used to see people die on the road. They get knocked by a car. The body stays there for a long time. I've not seen that ever since I returned to Nigeria. Thank God. So it means something is, people are more aware of the fact that you don't cross, use the pedestrian, crossing, or they're getting smarter. And drivers are also, looking out for pedestrians more than how it was before. Something is changed, something has changed, which is for the good. But RTAs are also something that, is so painful that RTA, just like, I experienced myself, that's an RTA with trauma, meaning the guy hit his head on the pavement and it was bleeding. And I looked closely, I saw he was bleeding from the nose and from the mouth. And that told me, that right there are things you could do. There are protocols you could actually administer to at least stabilize the patient.
Tell us about those, if you don't mind.
Sorry?
Tell us about those protocols, if you don't mind. So obviously, if he's bleeding from the nose and his mouth, then we're talking about a fracture at the base of the skull.
Correct.
So what could have been done in that situation?
So we have the ABCDE approach, which is the airway. First of all, look at this airway, make sure the patient airway is good. Then the breathing, assess the breathing, and look at make sure there's no pneumothorax. Although you can't find that out, right on the street, but there's some ways you can, assess the breathing. You look at the breathing level, then also circulation as well. The way you place the patient can actually, say a lot about if the patient is going to survive. So circulation, you make sure you look at the external bleed. If you see external bleeding, try to control that by, applying pressure to some areas. There's limited things you can do while on the road there, but if you take the patient to the hospital, those are things you can do. Then you look at the disability. There's something called the GCS, that's a Glasgow Coma scale. So you if the patient is able to talk, you can actually look at the for signs, the eyes. You make sure the pupil, check the pupils, and also sign of a head injury. There's some ways you can touch the patient. Then exposure as well. Make sure nothing is prevent try to get the patient body exposed so they can see everything that is happening, any bleeding in areas, any injuries in areas. Then you prevent hypothermia as well. So depending on where it happened and the condition, then once you do that, the next thing is if you're able to take the patient, transport the patient, the first thing is X-ray. Do an ultrasound to also see if there's internal bleeding. Then the next thing is you get your team together, your specialists, your orthopedics, your neurosurgeon, the general surgery surgeon as well. Get all these people together and now start administering treatment. So the trauma ER steps is the ABCDE approach that I mentioned. So A is for airways, B is for breathing, C is for circulation, D is for disability, E is for exposure.
Interesting.
Yeah.
So that's it. I like the way you laid it all out. So you're saying that this patient who was by the roadside that you watched die, something could have, his fate could have been different if you had been given the chance to step in?
Absolutely. I will follow those up. Those are those approaches that I laid out, even though I am, constrained to not having some equipment, but definitely I would have done some administer some treatment without, having the right, at least just to stabilize him. First of all, the way he's lying down, tilt him, look at the circulation, try to talk to him, try to keep him alive, ask questions. Are you breathing fine? Do you have issues breathing? Check, to make sure there's no any open wounds, apply pressure, try to control the bleeding. So there's several things you can do while the ambulance shows up. And guess what? If we had a dispatch care ambulance, which were one of our services, that patient would never have died, because everything you have in an ambulance, a Class C ambulance, we have that on the bike. So would have, just within 10 minutes, stabilize the patient, give them every treatment you would have administered in an ambulance, and would have saved that life.
That's amazing. Where's the place for elevating one's limbs?
So if it's a broken leg, I mean, there are ways you can actually do. You get you elevate the leg, to maybe a 45-degree angle, or depending on the extent of the injury. So if it's an exposed bone, you just make sure you keep it, make it stable, and then you wrap it up to make sure you prevent infection, you prevent, some more bleeding, and then you keep on talking to the patient again to keep them alive, to make sure they're cognitive, and while you get help.
Well, I was thinking about it from the perspective of the circulation is down. Maybe the person has been bleeding, and the legs are not priority right now. So we're trying to divert blood flow from the legs to the internal organs or the vital organs.
So you actually elevate the patient depending on the extent of the injury. So you elevate the patient to make sure the airways are clear, the passage of air is solvent, or if you actually put them on their side as well, sometimes, to make sure breathing is not impeded the way they're laying down.
How is bleeding impeded if they're lying down on their back?
Breathing is impeded. Breathing.
Yeah. How is it? Can you explain how it is impeded if they're lying down on their back as opposed to if they're lying on their side?
Fluid goes in. You have constant fluid movement. So depending on how you're laying down, if it's flat on the ground, you have fluid, and also the lungs as well. You have lung capacity issues. So the best way is to elevate, and that helps them breathe properly.
Elevate meaning be on the side?
On the side, or elevate up a little bit, like 30 degrees or 25 degrees from the ground.
Like putting a pillow under the chest, under the back side?
Yeah, depending on what you have, depending on where you are. If it's on the road, I mean, you can always use, whatever you find, as long as it's not something that is too hard.
Yeah.
And just use it to elevate the patient.
Not a rock. Don't use a rock or a
boulder. No.
So because the reason I'm asking is, okay, if a layperson comes across a scenario like you described, what can they do? Obviously, it's not ideal for someone who knows nothing about medicine to start administering first aid. But if that's all we have, what can they do to at least support the person who is in a precarious situation? What can be done to keep the person alive until help comes? That's kind of like where I'm going to.
Yeah, first aid. I mean, that's why education as well. First aid protocol. Not someone that is not a medical professional cannot administer some things. So one of the things we advise is engage the patient, engage the patient, talk to them, make sure they keep talking. Then the next thing is, if the person cannot talk, maybe compression, or do a CPR. So those are the acceptable, things they can do, a CPR, and again, the most important one is engage the patient. How keep talking.
And
Yep.
by CPR, you mean specifically mouth-to-mouth respiration, or what?
Yes.
Okay.
Yes. Yeah.
So that's CPR. Remember, it was cardiopulmonary resuscitation. That's what
Yep.
CPR is.
Yep.
Yeah,
Yep.
yeah. But that's if the person is not breathing. That's when you do that, though.
Exactly. Exactly. So there are different stages. That's why I said if the most important thing passersby can do is to engage the patient. Keep talking to them. Don't let them lose consciousness. Just keep talking and talking and talking while help is coming. Because they're kind of handicapped. They don't have anything to administer treatment. But the most effective one is to engage the patient.
Yeah, got it. Got
Yeah.
it. Well, this has been fascinating, Doc. This is very interesting stuff. I really hope somebody in government is listening to this, so that we can begin to see how we can implement. And I know with the present president,
Yeah.
that there have been a lot of changes and initiatives, and but I think in some cases we're overlooking the most basic things like what you're talking about. And so this really, really needs to be addressed. You're in Lagos, anywhere else in the country, or we're focused on Lagos for now?
Just Lagos for now. Yes.
Got it. Got it. Got it. Okay. All right. Well, thank you so much for giving us your time. We wish you all the
Sure.
very best.
Thank
Give
you.
us your website and contact information again.
Okay, it's www.healthhubafrica.com. So health hub with one H, Africa.com.
What do you mean 1H? Health Hub.
So health hub is health
Uh-huh.
spelled out. Then instead of two H's, one H. So you
Ah,
just continue healthhubafrica.com.
got it. So it's H Health, and then ubafrica.com.
.com, correct.
Got it. Got it. Got it. Got it. Okay. Good. Good to explain that. Excellent. Well, wish you all the best in this initiative. It's virgin territory, I can tell you that. So,
Thank you.
all right.
All
God
right.
bless. Take care. Now, folks, remember you can catch us up on our website, brainandbodyfoundation.org, and all the social media platforms. You can. I'm also on a lot on LinkedIn, but also on other platforms as well. I start tell me I'm on TikTok. I've never been on TikTok. Don't even have an app, but they're posting on TikTok as well. I guess most kids are on TikTok these days. So it's Dr. David Ajibade on all the social media platforms. God bless. Take care. Take care of your health, and we shall see you next week.